Yes, sir, in the very back.
Is there a different part of the brain that's involved with an incident, kind of traumatic, versus reading a passage and trying to memorize it?
I guess that one goes to me.
And remember to repeat the question. So, we can all
So
hear.
the question was whether or not there was a specific part of the brain that was involved in memory loss in traumatic brain injury. Is that correct?
No, the question was, if you're trying to memorize something and you sit down and study it, or if there's something that happens, an accident or something, and that impresses your brain, is it a different part of your brain that you use to remember those two different incidents?
Okay, so the question was then whether there's a difference in the kind of memory that is effortful, that is, I sat down and I studied a particular passage and I wanted to remember that or memorize it, versus I walked down the street the other day and I saw something that I would like to remember. Yes?
Traumatic experience.
So a car accident.
Okay, I saw a particularly bad, so everybody knew what the question was but me. Okay.
We become a really good community by the time we walk out of here.
Okay, so let's start with the effortful memory, the memory of I want to memorize a passage. There's a particular part of the brain that we use for that kind of memory, and it's called the hippocampus, and it lives here in our temporal lobes, deep in the temporal lobes, and there's one on each side. And it's an area of the brain that's been studied quite a bit. The reason we know that it's really important in memory is because it's an area of the brain that happens to be involved in the majority of epilepsies. Temporal lobe epilepsy is one of the more common forms of the disorder. And one of the treatments that is particularly effective, when it is particularly effective, is to take out the part of the brain that's causing the problem. And so one day, for one patient, they took out both hippocampi, and then the person never remembered anything for the rest of his life. In fact, he was living in his early 30s for the rest of his life. He could remember things for about 2 minutes at a time, 2 to 10 minutes at a time, and then they were gone. And that's how we learned that it was never a good idea to take out both hippocampi at a time, and that the hippocampus was a major seat of memory. And since then, we've learned a great deal more about it that maybe we can talk about later on. In terms of traumatic memories, there is, and so let's talk about something like PTSD. In this instance, it looks like what we're seeing is that, in fact, memory goes down in a normal way. It's transmitted through the hippocampus just as one would expect, but it's relived, and it's relived in sleep. So one of the jobs of sleep is to help us to both forget and remember, to help us put memories down and to refresh those memories, consolidate those memories, make sure that they stay where they belong, send them out to the parts of the brain that store them, make them retrievable, and then get rid of the things that we no longer need to remember. And in PTSD, that doesn't work. Instead, the memory is reconsolidated constantly. It's always brought up. It's like reverberating circuit. And in fact, because it's a highly emotional memory, it gets attached to that emotion more and more strongly. It seems that we have two kinds of memory that we're particularly good at keeping in our heads. One is one that has a strong emotional content to it, good or bad, and the other is something that smells good or bad. We do really well with olfactory, with smell. So those two kinds of memories seem to have kind of preference in the brain, and those traumatic memories, the reason they keep coming up, they almost get stronger over time, is that you almost can't break this cycle. And there's neurochemicals in the brain that we think are involved in that, but it's not really a different area of the brain that's putting the memory down and remembering it. Instead, it's a little bit more how we remember and forget. Does that answer your question?
Yes, ma'am.
So I had a long-winded one. So, prevailing thought from years ago was the hippocampus was important for episodic memory, and then you would get through a variety of chemical and electrical transmission back to the cortex, the storage for the long-term memory. So there was an article in Science about 2 weeks ago that sort of indicated that maybe that wasn't quite true, that you got the imprinting happening both in the hippocampus and the cortex. And the hippocampus was more active during a certain time period, and then the cortex would take over. How do you think that kind of finding will change the way researchers look at the pathophysiology of memory disorders, especially Alzheimer's and Lewy body?
Yeah, we've, a lot of that research.
Will you repeat the question?
Oh, yes, sorry, the long-winded question there. Okay. The question was essentially, you know, we heard a minute ago about the hippocampus having a role in memory formation and being able to take the memory and put it into storage more or less. That's been a classical model for many years. A lot of that was based on the research that was mentioned a minute ago with the unfortunate gentleman that had a bilateral temporal lobectomy and had the hippocampus removed from both sides. So he then had no functioning hippocampus, or so we thought. But it turns out Mr. Meliasen, his name was Henri Meliasen, and he passed away, and then his brain was examined, and it turns out the hippocampal destruction wasn't quite as complete as was thought. And so that's one line that leads us into thinking perhaps the hippocampus is not quite so prime in some of these memory formations. So, you know, what other structures could be important? That's an excellent question. How is that changing our research in Alzheimer's disease and how Alzheimer's disease affects people? Alzheimer's disease begins in the mesial temporal lobe and the inferior temporal lobe. So that's where we first see the pathological changes. And so we first see the damage done to memory formation. So the recorder is being damaged, so to speak. The recent research, it hasn't impacted us as much directly in Alzheimer's disease and in managing Alzheimer's disease as it might with some of the more we might call classical behavioral neurology, actually studying the procedures themselves of how these memories are stored. But it is interesting because it has challenged our old beliefs about how memory formation and memory storage works. Well, a lot of us have thought that the old models are a little bit too simplistic anyway, and a little too definitive. One of the things we learn in neurology, you know, early on is you learn which part of the brain operates which part of the body. So there's a little map and it shows these motor neurons operate that part. But then when we started doing epilepsy surgery and started doing direct cortical stimulation, we found out that everybody's a little bit different. And so people are wired up a little different. And so the way memory formation works is probably not quite as simplistic as we used to think. It's fairly complex, and you know, to say the least. So how those memories get from what we would call short-term memory and how they pass through working memory and then get passed into storage areas is not as well known. It's being challenged, the old theories, I think.
And can I answer another piece of this? There's another part that Mark brought up here that's important. So even this gentleman that we've discussed here, it turned out that not all of his memories were lost. He did very well on skill memory. If you handed him a puzzle and he learned to do the puzzle, he might not remember having done the puzzle, but he performed the puzzle the next day as though he had learned how to do the task. And that's called procedural memory. And that memory was intact in this individual. And so it was long thought that the hippocampus wasn't involved in procedural memory, and that perhaps this was a cortical function or some subcortical function that we didn't really fully understand. We now know the hippocampus is involved in procedural memory. So, as you say, it's complicated.
It's complicated, and there was still some of the hippocampus intact in HM, and so that's what muddies everything up. So the majority was removed. And so he had this severe recent memory deficit, but on the other hand, as you say, he could learn motor skills and, you know, and actually had some ability to learn some music as well, which is, you know, another area entirely, is musical memory.
Yes, ma'am.
Do you know if there is any research that, going on with veterans that have the syndrome? And is there any progress on how to deal with that?
There's tons of research.
Can you repeat the question?
Oh, sorry, the question was whether or not there,
I keep forgetting. Or memory for me.
the question was whether or not there was any research working with veterans who were suffering from PTSD and the memory deficits that go with it, or the memory conditions that go with it. And the answer is yes, there's a great deal of research. And not just with veterans. Veterans are not the only victims of traumatic injury that result in PTSD. Children who've been abused, rape victims, people who've been involved in major catastrophic events, such as terrorist attacks, for example. So PTSD is not uncommon, and there's a great deal of research in all of those areas. Have we gotten any place? Yes and no. So yes, for some individuals, there has been research that has pointed to areas where we've been able to help. So for example, there's a period in your sleep called REM sleep, rapid eye movement sleep. That's the sleep where we have the most bizarre dreams. That's the sleep where the dreams make no sense, where they're not cognitively rational. That's the sleep where emotion is strongest. And so we've gone back and forth about the role of REM sleep in PTSD. It clearly plays a role. And there have been a number of studies looking at REM sleep deprivation or changing REM sleep to see whether or not that will improve PTSD symptoms, and in some people it does. So research is moving forward there. It could hardly be said to have solved the problem.
I have two questions in conjunction. When do you make a decision when you're going through memory loss that it is time to go to a physician whether something serious is wrong? And secondly, do they do a test that can confirm dementia or Alzheimer's?
Well, that one would seem to be in my bailiwick, so I'm going to try to remember. Now, here comes prospective memory. Remembering to do something, right? All right, we have shown a deficit of prospective memory. We keep forgetting to repeat the question. So, the question is, at what point do you decide it's worth going to a physician over a concern about memory loss? And
Are there tests?
oh, and what are there tests that can be done that can confirm the presence of dementia? So let me kind of explain a little sort of primer in dementia and that sort of thing. So memory loss, there's some memory change, as my colleagues could talk about probably even better than I would. With advancing age, there's some memory change that we all experience. And a lot of that has to do with slowing down of mental processes, actually, and some slowing of frontal lobe processes which help with rehearsing memory and help with retrieving memory. So it gets a little harder to retrieve memory when you want to, so that people experience problems remembering the names of someone. So you see someone that you know and you can't remember his name. And I'm trying to introduce them to my wife and I can't remember who they are until they're gone in another part of the store, and then the name comes back to me. So, or I'm trying to talk, and I will exhibit this several times tonight, whatever I'm trying to think of to say just goes away, and I can't think of the words that I want to use. So, and some of that is quite normal. Also, absent-mindedness becomes a little more common with age, typically. So that means not paying attention in the first place, so that you can't remember, as I said on the radio, you can't remember where you put your reading glasses because you actually weren't paying attention when you put them down, so you don't remember where they went, and that may happen a little more frequently. So dementia, on the other hand, is defined as having a decline in memory or thinking ability that is enough to interfere with the ability to function. So that's a critical point, is the ability to function, the ability to, could this person live by themselves and get by? Can they keep their bills paid? Can they take their medicines on time? Can they remember to go get them refilled? Can they remember to go get food? Do they remember to eat? So these are important things. So when dementia means there is some decline and some impairment in the ability to function. Clearly, when somebody's not functioning well, they should be evaluated by a physician. And there are tests we can do which can confirm that there's cognitive impairment. Determining whether that meets the rules for dementia, the criteria for dementia, that depends on getting a history of how well somebody's functioning. So there isn't a scan, there's no blood test that you can do that will say, and I've heard people come in and they say, well, Dr. Smith said he got an MRI and it showed dementia. No, you can't see dementia on a scan. There's no blood test that will show that. So dementia is a clinical diagnosis. It means I can tell there's impairment though. I can do cognitive tests and I can say, okay, your memory's not as good as it should be for your age. I then have to couple that with the history that function is declining. Although sometimes we can impute that because if the cognitive score is bad enough, there's no way somebody could function, for example. So sometimes we can kind of tell that. So yes, there are tests we can use to determine whether there's cognitive impairment. We can couple that with history to tell if dementia is present. Conversely, we may be able to test someone and say, your memory is actually normal for your age. You do not appear to have dementia right now. And in fact, sometimes I'm able to tell people, you don't actually appear to have a memory problem right now. This is probably memory loss associated with age. And so it's also very important that those people go to the doctor because sometimes it turns out they're not sleeping right. They may have obstructive sleep apnea, for example, and they're not getting the appropriate sleep at night, and that may interfere with memory. So there are all kind of modifiable things that we can uncover. Or they're taking medicine to help them sleep, which is actually interfering with memory. And so, that's the whole subject we could talk about all night. But, so yes, there's a lot of reason for them to be seen. And what I tell people is, anytime you're concerned, anytime you think there might be a problem, that's the time to go to the doctor. Assuming that you go get sent to somebody who has experience in evaluating people with memory loss and somebody who knows how to apply these kind of clinical rules, then you can get an answer. And it's never wrong when people say, ooh, you tested me and I'm normal, I feel so ashamed, I shouldn't have come to the doctor. I say, no. We're the only ones that can tell that by testing you, so that's what we're there for. So anytime somebody's concerned, they should go and be evaluated, we believe.